Hello friends, today we are going to discuss about the physiologically difficult airway. So, a physiologically difficult airway is defined as one in which patient's physiological and pathophysiological alteration increase the risk for complication during tracheal intubation and transition to positive pressure ventilation. So, pathophysiological alterations such as hypoxemia, cardiovascular instability, right ventricular dysfunction, and increased intracranial pressure, as well as physiological alterations that occur in obesity and pregnancy, constitute the physiologically difficult area. About location and the factors increasing the risk of complication. Environmental and the human factors, in addition to the patient's physiological derangement, contribute to the an increased risk of complication during management of physiologically difficult airway. The likelihood of encountering patient with the physiologically difficult airway is higher in the intensive care unit and emergency department as compared to other location in the hospital. About team preparation and the human factor consideration. An appropriately designed intubation checklist that addresses the equipment, drugs, team role, composition, patient optimization, both primary and backup plans for airway management can reduce the errors of omission and may improve the patient outcome during the management of physiological difficult airway. The intubation team should consist of at least three healthcare providers during management of physiologically difficult airway. This should ideally include two airway operators, at least one of whom should be experienced. Assigning roles and responsibilities of team member, ensuring the shared mental model among the team members and discussion of primary rescue plan, gathering and interpreting information, as well as anticipating problems can improve the team performance during management of physiologically difficult areas. Post-procedural team debriefing can help improve team performance for the future management of the difficult airway. Training requirement for provider performing airway management in patient with physiological airway should be well defined. Simulation-based training should be a part of curriculum for provider performing airway management in patient with physiologically difficult airway. Now about patient optimization. The critically ill patients requiring tracheal intubation should be routinely undergo the pre-procedural airway assessment to screen for potentially anatomical and technically difficult airway difficulty. Screening tool that assess the factors beyond predicted anatomical difficulty such as MACOCHA and HYPE score may be used to identify patient at the risk of physiologically difficult airway. Patient with physiological difficult airway should be counseled about the airway management prior to the tracheal intubation if feasible. Now about hemodynamic monitoring and optimization. The minimum mandatory monitoring in patient with physiologically difficult airway undergoing tracheal intubation should include non-invasive blood pressure, continuous ECG, and pulse oximetry. Hemodynamics should be optimized prior to the tracheal intubation in patients with physiologically difficult air. Interventions such as vasopressor and inotropic infusion administration can help prevent and minimize peri-intubation cardiovascular collapse. Use of the peri-procedural point of care ultrasound, when feasible, can improve the safety of tracheal intubation by aiding assessment and the management of cardiorespiratory compromise. Cardiovascular collapse and hypoxemia are most common complications associated with tracheal intubation in critically ill patients. The experts reached the consensus on the value of relating monitoring modality, emphasizing the need for continuous ECG, continuous pulse oximetry, and non-invasive blood pressure monitoring as a standard practice during tracheal intubation of patients with physiologically difficult airway, especially when performing tracheal intubation in more remote areas of hospital where such a monitoring is not commonly utilized. Role of fluid loading and vasopressin. Two trial in critically ill patient suggest the lack of efficacy of 500 ml of intravenous fluid bolus prior to intubation. Then two ongoing international trials such as FLUA trial and prevention trial are investigating effectiveness of administering vasopressor in preventing cardiovascular collapse in critically ill adult undergoing tracheal intubation. Bedside point of care ultrasound can help identifying at-risk patients and provide real-time hemodynamic and cardiorespiratory assessment and may aid in physiological optimization in this patient, warranting further research. Now, the peri-intubation oxygenation and respiratory optimization. Peri-oxygenation with NIV is preferred method to minimize the risk of oxygen desaturation during tracheal intubation in patients with physiologically difficult air. Then apneic oxygenation using high flow oxygenation is an acceptable technique to minimize oxygen desaturation during tracheal intubation. Careful mask ventilation may be performed during apneic phase of rapid sequence intubation to minimize desaturation. In patients with physiologically difficult airway who are difficult to pre-oxygenate due to lack of cooperation, the benefit of sub-anesthetic doses of sedative hypnotic while preserving spontaneous ventilation may outweigh the risk. After cardiovascular instability, hypoxemia is the second most frequent complication observed in critically ill patients undergoing tracheal intubation. So, PROTRACT study showed no difference in primary outcome of lowest oxygen saturation during tracheal intubation in critically ill adult undergoing pre-oxygenation with high-flow nasal cannula or standard bag mask oxygenation for standard bag mask ventilation. Now, according to Florali 2 study, which randomized the hypoxic critically ill patient undergoing tracheal intubation to pre-oxygenation with NIV or high-flow nasal cannula, showed no difference in incidence of severe hypoxia. However, subgroup analysis suggested that potential benefit of NIV among patients with PO to FiO2 ratio of less than 200. Prior studies comparing pre-oxygenation using NIV versus bag mask or conventional face mask also found less oxygen desaturation with the use of NIV. In the pre-oxy study, pre-oxygenation with NIV resulted in lower incidence of hypoxemia than the pre-oxygenation with oxygen mask. Taken together, these trials suggest that in critically ill adults, pre-oxygenation with NIV or high-flow nasal oxygenation are superior to conventional pre-oxygenation. In addition, NIV may be superior to high-flow nasal oxygen for pre-oxygenation in patient with moderate to severe hypoxia. While exact setting for NIV and high-flow nasal oxygenation were not included in the statement, 100% FiO2 should be provided prior to or during procedure. In patient with high minute ventilation, flow of more than 30 ml per minute on high flow nasal oxygenation may be needed to avoid entrainment of room air. Similarly, high positive end expiratory pressure may be needed in patient with low PF ratio. This setting would be need to be adjusted on case-to-case basis. Now about delayed sequence intubation. Delayed sequence intubation using dissociative dose of ketamine to facilitate pre-oxygenation significantly decreases peri-intubation hypoxia compared to standard RS, justifying the use of delayed sequence intubation in patients who are difficult to pre-oxygenate due to compromised mental status. Now, patient position. Head elevated laryngoscopic position, also known as semi follower position with the head of bed elevated to 30 degree, should be used for tracheal intubation in patients with physiologically difficult air. The superiority of the sniffing and or semi-upright ram position, keeping the external auditory meatus level with sternal notch in facilitating glottic visualization and tracheal intubation is debatable. A randomized study in critically ill showed that RAM position was associated with increased tracheal intubation difficulty compared with sniffing position, although the use of suboptimal RAM position was an important limitation in this trial. The upright position improves pre-oxygenation and prevents the reduction in FRC and may reduce the risk of pulmonary aspiration. A prospective observational study and large retrospective study showed that improved first pass intubation success and reduced complication rates, respectively, with upright positioning compared to supine positioning during emergency tracheal intubation. However, hemodynamic status of the patient should be taken into consideration before placing patient in help position. Now about performing procedure, RSI and drugs for tracheal intubation. A modified RSI technique, sedative, hypnotic, and rapidly acting neuromuscular blocking agent, uh, neuromuscular blocking agent or gentle mask ventilation should be considered in patient with physiologically difficult airway to prevent peri-intubation complication. Cricoid pressure should be released in case of difficult with visualization of vocal cord during tracheal intubation in patient with physiologically difficult airway. Ketamine or etomidate is preferred sedative hypnotic drugs for tracheal intubation in patients. Standard anesthetic induction doses of propofol should be avoided in patients with physiologically difficult airway to limit the risk of peri or procedural cardiovascular collapse. Ketamine is safe to use for tracheal intubation in patients with this type of the patient uh, who are physiologically difficult and suspected or proven intracranial hypertension. Succinylcholine or rocuronium are preferred neuromuscular drugs during tracheal intubation in patients with the physiologically difficult airway. Succinylcholine should be avoided in certain situations such as patients with skeletal muscle myopathy, known allergy, history of malignant hyperthermia, hyperkalemia, and significant burn injury. Now, devices and tools to aid tracheal intubation. A video laryngoscope should be available during tracheal intubation in patients with physiologically difficult airway, and all operators should be trained in use video laryngoscope. Then video laryngoscopy should be routinely employed during first attempt at tracheal intubation in patients with physiologically difficult airway as it enhances glottic visualization and is superior to direct laryngoscopy in difficult airway management and aids in supervision and assistance of airway operator by providing shared view of glottis. A stilette and bougie should be used routinely while performing tracheal intubation using either direct or video laryngoscopy in patients with physiologically difficult airway. The Intubate study showed that video laryngoscopy use in only 17% of tracheal intubation in critically ill patients, and this could be because previous studies in critically ill have failed to demonstrate a clear benefit of video laryngoscope over direct laryngoscopy. However, sub-analysis of intubate study data demonstrate that video laryngoscope was associated with higher first-pass intubation success rate despite the higher prevalence of difficult anatomical predictors in the video laryngoscopy group. The use of stilette to facilitate tracheal intubation varies in clinical practice. In stilette for orotracheal intubation, that is stylo trial, using stilette during tracheal intubation with direct laryngoscopy uh, resulted in significantly higher first pass success rate. So the recently one trial was published in NEGM, that is device trial. So the conclusion of this trial was among critically ill adult undergoing tracheal intubation in emergency department or ICU, the use of video laryngoscopy resulted in higher incidence of successful intubation on first attempt than the use of direct laryngoscopy. Then about post-intubation care. Immediate post-intubation care of the patient with physiologically difficult airway include confirmation of position and securing tracheal tube, management of cardiovascular instability using vasopressor or fluid as appropriate, and any other complication. Then tracheal placement of tube should be confirmed using waveform capnography based on consistent rise in amplitude of EtCO2 during exhalation with decline during inspiration over at least 7 breaths. Chest auscultation, chest X-ray, and bronchoscopy are acceptable methods to confirm optimal depth of the tube in the trachea. A lung protective ventilation strategy, including tidal volume of 6 to 8 ml per kg of predicted body weight, positive end expiratory pressure, that is PEEP of more than or equal to 5, plateau pressure of less than 30, and FiO2 titrated to SpO2 between 92 to 95 should be adopted for patients with physiologically difficult airway requiring invasive mechanical ventilation. Then fluid responsiveness should be re-evaluated using dynamic indices before fluid administration in patients with physiologically difficult airway who develop hemodynamic instability after tracheal intubation. Continuous invasive blood pressure monitoring and central venous access should be established in patients with physiologically difficult airway who develop persistent hemodynamic instability after tracheal intubation. Then sedative and hypnotic infusion guided by clinical assessment of depth of sedation should be employed after tracheal intubation with neuromuscular blocking agent in patients with physiologically difficult airway to reduce the risk of accidental awareness with recall. Thank you guys.